G'day guys, my name's Callum Flanagan. I'm a registered paramedic and today we're going to be taking a walk through an advanced assessment of a patient presenting with a specified complaint. The patient, which you'll be seeing on the screen right now, is of a 68-year-old male complaining of shortness of breath. We're going to be delving into an advanced history and respiratory physical examination for this patient and trying to narrow down what's going on with this patient in the most efficient way. Now that we have an understanding of what this case entails and we've got a brief overview of the presentation of our patient, we're going to delve into now the models to which we're going to employ to assess the patient. So primarily we're going to be working off the Pendleton ETL 1984 consultation model. In conjunction with this model, we're going to be using specific extracts from the neighbour 1987 consultation model and the Calgary-Cambridge model of 1996. Okay, so on your screen right now is the Pendleton ETL 1984 consultation model. This model, as well as the Calgary-Cambridge model of 1987, will be the two most prominently implemented models throughout this examination process. As you can see with the Pendleton ETL model, it is very patient-centered. It starts by defining the reason for the patient request, or for paramedics, the call-out. We consider potential differential diagnoses. Then, as we said, patient-centered, providing the patient with autonomy for self-determination. We consult with the patient to consider and choose appropriate action for each of the problems identified in the initial assessments. From there, we arrived at a shared understanding of the patient's presenting problems, management and treatment pathways. We involve the patient with the management and encourage them to take responsibility for their health. Also, in addition to this model, we will be looking at implementing and using time and our resources appropriately, and crucially, less so in a stepwise approach, but all over, we'll be establishing and maintaining a functioning relationship with the patient throughout our assessment. Supporting this approach will be the Calgary-Cambridge consultation model of 1987 that you can currently see on your screen. You can see it's a very simplistic and stepwise approach. It starts with initiating the session, which would be communicating to the patient and identifying who you are and gathering information on who they are. Secondly, you'll be gathering information regarding the circumstances of the event, events leading up to the incident, all this sort of advanced history taking required that will be displayed later on. Then we'll be moving into a physical examination, which will also be demonstrated shortly. An explanation and planning with the patient regarding the management steps and treatments that will be taken. And then we'll be closing out the session by transporting or leaving the patient behind. Okay, now that we have a brief understanding of the two major consultation models we'll be implementing throughout this examination process, I'm now going to walk you through an advanced history taking and advanced respiratory physical examination of our 58-year-old male complaining of shortness of breath. Okay, so our main priority, in accordance with Pendleton ETL 1984 and the Cambridge consultation model, is to identify why we're here after initiating a session. So in order to do this, we're going to run through a primary survey after making patient contact. So, g'day mate, my name's Cal, I'm with the ambulance service. What's your name? Okay mate, what's going on today? Righto, so a bit of shortness of breath. Do you mind if I just listen to your chest really quick? Okay. So just take a deep breath in for me. Beautiful. And again. Lovely. Alrighty mate. Do you mind if I just feel your wrist really quickly? Sweet. Okay, so from our quick primary survey just then, we've identified that we've been called out to Blake, who's experiencing a shortness of breath. We have identified in our primary that he was able to talk to us, indicating that his airway is patent. There was no audible stridor or any signs of obstruction in his airway. Moving forward, we auscultated, and upon auscultation, we heard that there was mild expiratory wheeze occurring in the upper airways. Moving forward, we went and felt his radial pulse. From here, we identified that at the moment his heart rate was feeling normal. From these initial findings, I believe it is warranted to administer the patient 5 milligrams of nebulized salbutamol at 6 litres per minute via nebulized face mask in order to address the audible expiratory wheeze upon auscultation. From these mentioned initial findings in the primary survey, it would seem the patient is suffering from some form of respiratory origin of distress. In order to narrow down a diagnosis and confirm these findings, I'm now going to perform an advanced history taking. Whilst I'm performing this advanced history taking, I'm going to have my partner perform an ECG in order to rule out any potential cardiac origin of distress. For this examination, I will follow the sample mnemonic in history taking. Okay, Blake, so you're telling me you're experiencing a bit of shortness of breath. Yeah, okay. What caused this shortness of breath? Was there an incident that caused the onset? Yeah, you're bringing in the groceries. How long ago was that, mate? About 40 minutes ago. Okay, has it been consistently, have you been consistently short of breath since then? Pretty much? Okay. Have you ever experienced this shortness of breath before? You have? Okay. Do you have any medical conditions I should be aware of? Any COPD? Any asthma, anything like that? No, you don't? You don't have any respiratory or cardiac conditions? Okay, you've got high blood pressure. And that's all you know of? No other respiratory or cardiac conditions? No? Okay. So you're saying you've experienced this sort of shortness of breath before. Well, how often do you experience this? Okay. So it's been coming and going for the past month, essentially. Righto. Has similar triggers, so when you're exerting yourself, is this how it usually comes on? Yeah? Okay. Okay, Blake, so with this shortness of breath you've been experiencing for about a month now, coming and going for about a month, has there been any associated symptoms? Have you had a cough at all? Yeah, you've had a cough? Okay. Has this cough been productive? Have you been coughing things up, or is it just a dry cough? You've been producing stuff. Okay. Have you managed to have a look at this production? Is it, do you know what colour it is? Yeah, alright. So it's like a green, sort of yellowy sort of stuff. Right, okay. Now that we have identified sufficient detail regarding the signs and symptoms of this case prior to a physical examination, we're now going to complete the sample mnemonic and move on to further investigation. Okay, Blake, do you have any allergies, mate? No? Okay. Do you take any medications? Yeah? So you got your beta blockers? Is that just for hypertension? Yeah, okay. Righto. Do you take any other kind of medications? No? So no over-the-counter medications like Panadol or anything like that? You do take Panadol? Okay. What do you typically take Panadol for? Just usual pains, headaches, fever, yeah, things like that? Okay. How often would you say you have these sort of headaches, and just a regular amount? Yeah, okay, so you'd say once or twice a month, okay, and you'd take Panadol then once or twice a month. Yeah, okay. No other use of Panadol outside of that? Too easy. No other medications you take at all? So illicit drugs, any herbal medicines, any remedies like that? No? No? Take any vitamins? No? Okay. Righto. Do you have any past medical history excluding the hypertension, mate? No, not that you know of. So no history of any cardiac conditions, no respiratory conditions, no asthma or previous heart attacks? No? Okay. You haven't had a stroke or epilepsy before? No? No history of diabetes? Anything of the sorts like that? No, okay, so just the hypertension. Righto. So, when was the last time you ate, Blake? About 50 minutes ago. So about 10 minutes before the onset of shortness of breath. Okay. Righto, and the events leading up, as we discussed before, was just you going outside, bringing groceries in, and then you started to feel this shortness of breath. Is that right? Yeah, okay. And that was about 40 minutes ago, wasn't it? Yeah, right. Okay, Blake, so I'm just going to ask you a series of questions, mate, surrounding your occupational, social and family history. This is just getting me a bit better idea of what's going on and help me with my diagnosis to see if there's any external factors contributing to your current incidence of shortness of breath. So please feel free to say I'm delving too deep, but remember this is me just trying to help So I was just wondering if I could get you to tell me what your occupation is. Okay, so you're a cotton farmer. How long have you been a cotton farmer for, mate? 40 years. Righto. Do you do it largely yourself? Do you have a workforce, or largely yourself? Yeah, pretty small farm. Okay. So you've just been is that all you've done throughout your whole life? You've just been a cotton farmer on your own farm? Yeah? Inherited the family business? Right. Okay. So, in your family, has there been any history of this sort of illness? Any history of respiratory distress? Your dad had it? Okay. What did your dad have? Your dad had lung cancer. Okay. Righto. Was your dad a cotton farmer as well? He was? Okay, how long did he do it? He did it his whole life as well. Okay. Was he a smoker? Righto. Are you a smoker? No. Okay. You never smoked in your life? Nothing like that? Okay. Righto. So, does your family have any other history? So, did your mum have any cardiac conditions, anything like that? No? Don't know history within your family of any other respiratory or cardiac conditions? So, just your father had lung cancer, right? Okay. Social-wise, do you drink a lot? Wouldn't say a lot. Do you have a beer every now and then? Yeah, every now and then down the local. What would you say your weekly intake of alcohol is? 3 to 4 beers, right? And we addressed you don't smoke? Not smoke. You don't take illicit drugs, we talked about? No. Okay. Okay, now that we have completed our history examination, we're going to go forth with performing a physical respiratory examination. In order to do this and allow patient autonomy, we're going to give them information surrounding the examination we're performing so they can make an informed choice whether they'll go forward with it or not. Alrighty, Blake. So now that we've finished our history taking section of this assessment, I'm going to go forward with a physical respiratory assessment. What this will require is for your chest to remain exposed, and I'm going to perform a series of palpations, which is me running my hands in a stepwise approach across your chest and back. I'll also be performing percussions, which will be me placing my hand on your chest and back and tapping, listening for sounds. I'll also perform auscultations on your chest as I go across again in a step ladder approach and on your back. Are you comfortable with me performing these procedures? Okay. As well as this, I'm also going to be making examinations of your hands and arms. I'll also be requiring potentially for you to perform some tests. I'll explain them in more detail as we approach them if I deem them necessary. Are you okay with performing this as well? Okay, beautiful. Thank you, Blake. So we'll go forward with our examination now. Okay, so now that we've gained consent from the patient to perform a physical examination, we're going to be going into following the Macleod's process. This process is supported by Rickards and Proctor 2020. This process involves following an IPPA structure, which is inspection, palpation, percussion, and auscultation. So in order to perform inspection, firstly we're going to expose the patient's chest with consent, removing their clothing. From here we're going to be making a generalised impression of the patient's chest and body. We'll be looking for accessory muscle use in the neck and chest. We'll also be looking for sternal indrawing or intercostal retractions. We'll be looking for central cyanosis or peripheral cyanosis. We'll be inspecting the fingers for clubbing, any signs of CO2 retention. We will ask the patient if they're able to raise their hands up, holding their hands out flat. If we see a flapping tremor, this can be a sign of ventilation failure and CO2 retention. From here, we will move into performing our palpations. Okay, now that we've performed a inspection of the patient's general presentation, we're going to be moving forward into our palpation. In order to complete our palpation, firstly, we're going to be feeling for a symmetrical chest rise and fall. On the front section, we'll be doing this by holding our hands, as you can see my thumbs there, just below the chest on the ribs. We'll be looking at our thumbs for equal and symmetrical rise and fall. We're doing the same thing posteriorly on the back and looking for equal rise and fall of the thoracic cavity. Moving forward, we'll be palpating across the patient's chest. When doing this, we'll be looking for any signs of redness, any notion of swelling that could indicate edema. We'll also be looking for any patient tenderness, any complaints of pain, and we'll also be looking for any signs of guarding from the patient, protecting or trying to move your hand away from palpation. This can indicate pain also. We'll do the same on the patient on the posterior on the back. We're getting the patient to sit forward and completing the same crosswise manner palpation. Again, looking for the same symptoms of guarding, swelling or edema. Okay, so coming in a bit closer now to have a bit of a closer look. After performing our aforementioned palpations, we will be looking for tracheal deviation by using our index finger to inspect the suprasternal notch and looking for any deviation on either side from this center point. Once this is completed, that will conclude our palpations and we can move forward into performing our percussions. When performing percussions, with your least dominant hand, place the middle finger of that hand on the area to be percussed. Raise the second and fourth fingers off the chest surface in order to avoid dulling both the sound and tactile vibrations. With your dominant hand, tap the middle finger in between the site of the proximal and distal interphalangeal joints. Repeat this tapping as you move along the chest wall. It's important to make note of the sounds to which the percussion causes. In order to capture this most efficiently, with your dominant hand as you strike, pull the striking finger away as quickly as possible. This will allow the sound made within the lungs to resonate. If you hear a hyper-resonant sound, this is indicative of air in the lungs. This sound will sound hollow or high. If you hear a hypo or dull sound, this is indicative of fluid within the lungs. And if you hear a solid or flat sound, this is indicative of striking over a bone. Also, be cautious of the shape and location of the liver. Hypo-resonant sounds or dull sounds indicative of fluid will be produced by the liver from the 5th, 7th and 9th intercostal spacings depending on location. The following image gives clearer identification as to the shape and location of the liver and where the estimated hyperresonance will occur. Okay, so now that we've done our percussion, we're going to be moving on to auscultation of the patient. Here we're going to be following the Fern and West 2008 stepladder approach, which is moving across the chest, down, across the chest, down, and across the chest. We'll be doing this anteriorly and posteriorly before moving into a lateral assessment in a different method. We're going to be following the Dougherty and Lest findings that the bell is best used for locating an abnormal lung sound. Once you've located an abnormal lung sound, you'll then move over to the diaphragm of your stethoscope and examine that abnormal lung sound. Begin at the apex of the heart, represented as 1 in this diagram, and make your way down using the stepladder approach to the lower lobe of the lung, represented as 12. Auscultate in the intercostal spaces at the respective numbers. When performing auscultation, ask the patient to breathe deep breaths in and out through their mouth. When performing auscultations, listen for inspiratory stridor, which can indicate airway obstruction. Also, listen for inspiratory and expiratory wheeze, which can indicate bronchospasms. Also listen for coarse crackles, which is an indication of fluid in the lungs, occurring in incidences such as pneumonia or pulmonary edema. Also listen for fine crackles, which can be an indication of pulmonary fibrosis. The physical respiratory examination reveals that Blake has wheezing in the upper airways
and coarse crackles in the lower lobes of the lungs. These findings indicate that Blake is experiencing bronchospasms and potentially fluid in the lower lobes of the lungs. This could indicate that Blake is experiencing pneumonia, or more likely, due to his occupational history, pneumoconiosis. This should be referred to GPs and followed up as the patient's state is stable.